Hey guys, so today I'm going to be talking about medications used in diabetes, specifically type 1 diabetes mellitus and type 2 diabetes mellitus. So let's just jump in here. So we're going to start off with bigonides. The pretty much the backbone is metformin, and you're going to see this in most type 2 diabetic medication regimens. And how it works is that it inhibits gluconeogenesis in the liver, which decreases glucose expressed from the liver. And I usually like to think of this as metmorphin time because you're stopping that morphing of the glucose. And it's seen to significantly decrease A1C by at least 1% and BGL levels. There's also a decreased CV risk using it, and it's also weight neutral. So there's a low risk of hypoglycemia when you give it as monotherapy. Some adverse effects is GI upset, so that's mostly your diarrhea and abdominal pain, and lactate acidosis is another one, due to its blocking pyruvate dehydrogenase, and vitamin B12 deficiency, which I wouldn't worry too much because that doesn't occur unless the patient has been taking it for almost at least 10 years now. And then you also got the metallic taste. I think the most important one to know is probably the lactate acidosis, and that's because that um, that's one of the reasons why it's contraindicated for certain reasons like renal impairment um, and hepatic impairment as well. But hepatic impairment is more due to the mechanism of action on the liver. You also want to hold for 24 to 48 hours before giving iodine contrast due to the AKI. AKI is acute kidney injury, and that's again due to the lactic acid. And same for the surgery and heart failure as well. Oh, and just another note that metformin is safe to take in pregnant and breastfeeding, especially if the patient develops gestational diabetes as well. Usually first line is usually insulin. Sulfonylureas. So first generations, we got tobutamine, clopramide, which probably you won't see unless it's in diabetes insipidus treatment. And then you got the classic gliberides, glipzide, glimepiride, glycosides, pretty much anything that starts with GLI, so glies. Um, Glyburide you want to avoid in type 1 diabetes. And then glycosides are fast acting, but you want to avoid those in pregnancies. Um, I believe glimepiride is, well, actually, majority of them are avoided in pregnancy, but I think glimepiride is one that's actually safe in breastfeeding. Mechanism of action, it mimics the effect of glucose on the body, eliciting the release of insulin. And so probably the main thing you need to know about the class is more about the side effects because you hardly usually see this one because there's usually better options. So pretty much the main one you'll see is the weight gain and the high risk of hypoglycemia as monotherapy. Whereas in the other ones, you'll just see it more, the risk of hypoglycemia is more apparent if you use it in combination with another anti-diabetic medication. He also has the increased risk of CV events. So this class, generally, why you'll see it mostly used is because it's really cost effective. And oh shit, okay, I was sorry. So it wasn't glimepiride, it was the glyburide, which is used in breastfeeding. Sometimes it gets all muddled up because of the glies. Sorry about that, guys. So GLP-1 agonists. So that's your glutides. And so you got your liraglutide, exenatide, deuclide, and semaglutide. All pretty much are parenteral with semaglutide also having an oral formulation. And I just kept the name Ozempic in here because just because it's gone in popularity for a while. So there is special things need to know about it, which I'm going to go over. But first, let's talk about the mechanism of action. It mimics incretin to stimulate glucose-dependent release of insulin and glucagon secretion, slow gastric emptying, telling the brain that it's full. So basically, it's increasing that satiety. And if we're doing that, you'll notice that you'll get weight loss with it, which is probably the biggest, uh, actually probably not maybe an adverse effect. Maybe that's probably a good effect, if anything, because majority of the patients that take it are overweight anyways. And as you know, decreased weight loss that comes also with decreased CV events as a result. You'll also get no hypoglycemia as monotherapy, and you'll also see like most of the doses are usually titrated. So if you work in a pharmacy, you'll sometimes see like the Ozempic given 0.25 milligrams once a week for 4 weeks, and then you titrate it up to zero point 0.5 milligrams. And that's just to avoid the nausea that comes with it. You also want to avoid pancreatitis and possible thyroid tumors. And then again, this is just reiterating the fact that you want to avoid the thyroid carcinoma and history of pancreatitis and gastroparesis because it slows the gastric emptying. Okay, so this is just some details you need to know about Ozempic. One is that you can keep it at room temperature for about 56 days, um, whereas most insulins you can only keep it at about 28 days. And if you miss a dose, you need to take it within 5 days after you miss it. And if it's greater than 5 days, then you just skip the dose and take the next dose on a regular scheduled day. So, for example, let's say if your dose is usually on Sunday, you have till Monday, Tuesday, Wednesday, Monday, Tuesday, Wednesday, Thursday. So you have about till Friday to take the next dose. If you miss that, then you'll just have to skip it. You can also change the day of the weekly dose if the last dose was taken 2 or more days before. So if you normally get it done on the Sunday, you can change your day to the Tuesday. Okay, so this is our DPP4 inhibitors. Mm, Sorry about that. So these are basically your gliptins, and how I remember it is you dip your Lipton tea. So dip as in DPP, and then gliptins. So you got your sitagliptins, linagliptins, and then these two are highlighted red, saxagliptin and alogliptin, and that's because they should be avoided in heart failure because they can make it worse. So these are similar to GLP-1 agonists. So this is why often in therapy you might not see them together because they kind of work on the same pathway. So it inhibits DPP4, which prevents the degradation of GLP-1 receptors. It's a weight neutral drug and it is affected by CYP interactions, so just make note of that. So you can get pancreatitis, hepatitis, nasopharyngitis, which is like flu-like symptoms, and it's also unlikely to cause hypoglycemia as monotherapy as well. Okay, SGLT2s. Okay, so these ones are kind of making a big impact at the moment. So these include your classes like glyphosins, and there's just a list there. Probably empagliflozin is the one you're going to run into most. Canagliflozin, you just need to know one odd fact about it, which is the risk of amputation. And then you also got your dapagliflozin, which is Froxiga. So they basically work on the sodium glucose co-transporter in the proximal tube of the nephrons to inhibit reabsorption of glucose. What you're essentially doing is you're just peeing out glucose, right? And like I just mentioned before, although it's used in high diabetes, actually I don't know if I mentioned it before, but although it is used in diabetes, it's also kind of making it's also now being used in heart failure within the quadruple therapy with a reduced ejection fraction of 40%. So adverse drug reaction. So like I said, you're basically peeing out sugar. So that's a great great source of food for UTIs and yeast infections. So you're going to be more susceptible to those. It also decreases your blood pressure because it somewhat acts as a diuretic. So you want to avoid the use of loop diuretics or at least use it in caution because it can increase the risk of hypotension. And the reason I say with caution, so I wouldn't say really avoid the use, but you should use it in caution because sometimes you're going to need to get rid of that fluid overload within heart failure as well. And like I said, it's now used in heart failure, so you'll kind of see the two together. But just be cautious that you and be aware that it will cause the hypotension. And it's unlikely to cause hypoglycemia as monotherapy, and you might get diabetic ketoacidosis despite normal blood sugar, and it can also cause hyperkalemia as well. Okay, alpha glucosidase inhibitors. So these are kind of like the odd ones. So you got acarbose and miglutal. Honestly, probably acarbose is the one you really need to know. That's probably the one you'll see more often. And I usually think carbs, and then carbs usually get absorbed in your stomach. And basically how it works, similar to fiber, delays the gastrointestinal absorption of carbohydrates by inhibiting intestinal enzymes. So eating high fiber foods, but glucose levels don't raise that much. So just another important point about this, these medications need to be taken in with food in order to have effect. And since there's 3 meals a day, you're going to typically see a TID dosing. So basically your breakfast, lunch, and dinner dosing. Just don't use it. It's not usually recommended to use in patients with IBS or IBD because you can make the condition worse. And if patient becomes hypoglycemic, because of its mechanism of action, um, you'll need to give straight glucose in order for it to be absorbed in the stomach, not sucrose. It is weight neutral. Some adverse effects you may get is flatulence, diarrhea, and hepatitis. Thiazolidinones or TZDs. Okay, so with these ones, I don't think you're ever going to see it in therapy, but you will see it in questions because they're really popular in terms of their side effects. So pretty much, you just need to know pioglitazone and rosiglitazone. And what they do is they increase insulin sensitivity and absorption in certain zones. So notice how they end in zone of the body. So that includes like adipose tissue, liver tissue, and muscles. It does not affect the beta cells, so it won't cause hypoglycemia, but they do have really big side effects. And one of them is rosiglitazone, which kind of looks like it says rose, and I kind of got this mnemonic from Cram the Pants. So if you kind of remember that you give a rose on Valentine's Day, which is associated with the heart, you'll remember that it increases that CV risk, leading to an MI. And then pioglitazone is the only one that has a P in its name, and the bladder holds P, which also increases the risk of bladder cancer. And then other contraindications, don't use it in heart failure, liver disease, or history of bladder cancer. Okay, let's get to the fun part. So insulin. So here's kind of like a list of it. Rapid, short, intermediate, long. I'm not going to go too much into detail. The table's there. But one acronym that kind of helps is RIZL. And RIZL, so rapid, short, intermediate. And the reason this kind of helped me remember it is basically the RSI is going to be your bolus doses, and then L is going to be the long acting, which is your basal doses. And uh, rapid, short, intermediate kind of goes in that order of like um, the onset of action, the peak, and duration. So you can kind of see it's like decreasing in that direction. And then long acting obviously is going to have pretty much the biggest one out of all of them, including duglutic, which causes a uh, 42 hour duration. Um, there we go. So yeah, like I just said earlier, so when we give it as a bolus dose, it's obviously going to give TID, breakfast, lunch, dinner. Um, a note for rapid insulin, you can take it up to 2 minutes before a meal or 20 minutes after starting. And then long acting is usually given as a basal dose, which makes it great for nocturnal hypoglycemia. And then I guess another thing you can remember for rapid acting, honestly, I feel like rapid acting and long acting is probably the biggest ones you should know. Um, and pretty much all you need to know is kind of like Lispro and Aspart will probably be your biggest ones that you need to know. And then for this one, for long acting, probably the ones you'll run into more is Detamir and Deglutic as well. So if you kind of just remember lag for rapid, it kind of gives you. So you can remember rapid. Um, rapid does not have as much of a lag effect. Um, well, I guess it kind of does have a lag to 5-15 minutes, but I just kind of remember it because the LAG, right? And then long acting, not really any way I can think of remembering that other than DDG, but I think that would just confuse people more. Oh, and another thing to interesting thing to note is you won't get tested on this, but I think it's more like real world application. Is NPH has a cloudy appearance. As you know, you usually associate cloudy appearance with contamination, but NPH is the only one with a cloudy appearance. The rest will be a clear appearance. So this is more facts about insulin. If type 2 diabetes requires insulin, only give basal insulin, so long acting. For type 1 diabetics, usually an insulin regimen of bolus and basal is given. Daily insulin should be about 60% bolus, which is going to broken into TID dosing, breakfast, lunch, dinner, and 40% basal at bedtime. So what that kind of looks like is if a patient requires 25 units of insulin as their daily insulin dose, then your bolus, which is 60% of 25, would be 15 units, break that up into TID dosing. That would be 5 units at breakfast, lunch, and dinner. Your basal will be 40% of that, which is 10 units at bedtime. Now, an alternative to basal dosing is you can use NPH, which is an intermediate one, which is dosed BID. So then that 10 units would then become 5 units in the morning and 5 units at bedtime. In terms of adjusting dosing based on the patient's blood glucose readings, you'll want to adjust the previous administered dose. So, for example, that would be something like if their lunch blood glucose is too high, then you adjust the breakfast dose. If their breakfast blood glucose levels are too high, then you adjust the bedtime dose. And then injection sites is usually your abdomen, buttocks, upper arms, and thighs. And some adverse effects is hypoglycemia, lipohypertrophy, which is why we rotate the injection sites when we inject. And you also get weight gain because it promotes the uptake of glucose into fats. It can also be used in the treatment of hyperkalemia as insulin pushes potassium into the cells. And then it's also safe in pregnancy and breastfeeding, and oftentimes you'll see this first line in gestational diabetes. Okay, guys, I'm hoping that helped a lot of you out. If you find these videos helpful, kind of leave a comment below so I kind of get an idea, or if there's anything you want me to talk about. But yeah, good luck with your exams.